Good evening, everyone, and thank you for joining for our monthly LEJEndo webinar. My name is Ben Mondelli. I'm a consultant gynecologist working in Guildford, and just gonna introduce the team. So we have Mikey Adamczyk, that is a consultant gynecologist working at St. Peter Hospital in Chertsey and also at the Lister Hospital in London. We have Flo Britton, that is ST6, currently the fellow for Mr. Shane Casali, and yeah, my screen next to her, I can see Pavli Dmitrievich, which is hopefully going to be the next fellow for Mr. Casali, and currently working at King's, if I'm not wrong, as ST4. Moal Karfan is my colleague and is a senior registrar working at Guildford and doing currently a fellowship with Andrew Kent. Then we have Avril Baci, but she's almost a consultant actually. She's ST6 to 7, working at St. Peter Hospital and a previous fellow for Mr. Casali. And we have Oscar Barnick, which is going to be finishing now in October. So pretty much a consultant already and starting soon a fellowship with Shane Casali Minimal Access Surgery. And we have also Hannah Bank, which I will introduce better later on, but she's a senior statistician and she will present a really nice paper on the characteristics of women with endometriosis. Most people actually watch this webinar when they have some time because we upload it either on Facebook or on YouTube. So I think we can already start with the first two papers. But first, I would like to thank you, Carl Storz, which is facilitating this and is incredibly helpful in making this possible. And the LEJEndo webinar has been made in collaboration with the EEL, the European Endometriosis League. There is also Shane Casali, that is instrumental for LEJEndo, which today couldn't be present and sends his regards. I think he's doing a long clinic today. In the team, in the call, there is also Isabel Ward, that is a senior statistician, which again was instrumental for the paper which will be presented by Hannah today. Unfortunately, Isabel had got like a little bug, so she has lost her voice. So the paper will be presented by Hannah. I think our first short paper will be presented by Oscar.
Yeah, thank you, Ben. I'll just let Flo change the slides for me. Flo, are you able to?
Yeah, you can't see the slides moving there. Let me
Not
just
yet.
let me just reshare.
Thank you.
Can you see them move there?
Not yet. We just seen I started sharing the screen.
Oh dear.
Oh.
Bear with me.
Okay, yeah, we can see.
Yeah, lovely. Thank you very much. So this is just a quick presentation of a recent publication in Facts, Views and Vision, which is a short study comparing the learning curves of robotic-assisted and laparoscopic surgery, especially in gynecology, and it aimed to be a systematic review by a team in Italy. Essentially, the main objective was to try and compare a learning curve between these two types of operation. And they went through a big systematic search and found 6 studies that met their inclusion criteria. Mainly, they needed to be English studies, and they came to 545 women in total being operated on. The main inclusion criteria was using some form of objective and reproducible learning curve tool assessment, and I think that was a real challenge for them. So they actually lost a lot of studies due to a lack of a reproducible learning curve assessment tool. The procedures involved varied from radical hysterectomy, BSO, lymphadenectomies with hysterectomy, and also some papers looked at sacral colpopexies. Next slide, thank you. So these are the 6 included studies. If we look at they looked crucially at the characteristic of the surgeons, because obviously the experience level of the surgeon is going to have a potential impact on the learning curve with which they approach the operation. So the first paper that they found in 2011 actually used a surgeon with minimal laparoscopic training, which is obviously a really useful way of looking at a learning curve. Other studies used experienced laparoscopic surgeons when converting to robotic surgery. A few of them weren't recorded, unfortunately, and a few used, one paper used fellowship trained urogyne trainees for sacral colpopexies. Overall, or just go back to that one if that's okay, Flo. So the method used really varied, as you can see in the fourth column, method to assess the learning curve LC. There was no coherent use between any of these studies, and I think that greatly impacts the way in which you should read the results, unfortunately. And actually, the main finding take home from all of this will be that there isn't a good way of assessing the learning curve, and potentially that's what needs to change. The main outcome was the operative time, and we can have a look at the next slide. Essentially, in 2 out of the 4 studies that involved radical hysterectomy, BSO, and lymph node dissection, there was a shorter learning curve for robotic surgery, and in 1 out of 2 for the sacral colpopexy. But obviously, the learning curve metrics were very varied. What they did find was that in the papers where the surgeon had prior laparoscopic experience, they did reach the robotic sort of proficiency at a much faster rate, and that's something that we've seen in other papers already in the past, and something that obviously Intuitive and other companies do state. Essentially, the main recommendation and the main take home is that we need to conduct some form of I think they recommend an RCT, but I think that's going to be very challenging, but some form of statistically controlled study that involves surgeons that are naive to either laparoscopic or robotic or both, and have maybe multi-arms to try and look at the learning curve and use a very standardized learning curve evaluation tool, of which there aren't really, and even that might involve some work. But it's still interesting to see, and certainly as trainees are coming through with more and more robotic training, it'd be nice to know what sort of learning curve they're going to have. Thank you very much, guys.
Thank you, Oscar. I think it's a very difficult study to make, seriously. I mean, how do you quantify? Depends really on the person, depends on the case, depends how much experience you had. I think Mike is going to start soon his robotic training at St. Peter. Hopefully, I'm going to start soon in the next years or so. So it's going to be interesting. And in your experience, Oscar, because I think you have done quite a lot of robotic in the last year or 2 years, what do you think? Much quicker to pick up?
It's got to be quicker to pick up. And obviously, you've got the added tools of the fact that they have such a robust training program that you can pick up the skills that are required without actually operating on a patient. So I guess obviously that training does take time, and that's maybe similar to sort of lap box training, but more quantifiable because they give you the data. So you can see how long you've spent on these training tools and what your improvement in time and ergonomics and everything else is. So you get this really detailed feedback in a way that you don't for lap. But I think in general you'll notice it's a quick learning curve when you know the operation already.
By the way, if anyone has any question, feel free to write them in the chat, and we're gonna try to answer all of them. Shall we move to the next paper?
Oh, perfect. Thank you for the invitation, and thank you for Storts for sponsoring and facilitating this journal club. So I always try to pick topics which are the least kind of attractive in a way, but I hope that it may change some people's practice and help some people's patients. So this was a paper that investigated what forms of pain education helped the patients improve. So this is, we're talking that would usually be run with a psychologist in an MDT taking care of these complex patients. And if you can skip to the next slide, the main inspiration behind this is, around 20 to 30% of women will have pelvic pain. and then 20 to 40 of the ones that get operated will continue to have some element of pelvic pain. A lot of these patients in their journey, especially in the UK, I don't know if people are listening from other countries, do have a very long journey before they get one of us to operate on them. A lot of the times they're ignored. A lot of the times they hear things like it's all in your head. So the study basically compares what kind of buzzwords or concepts did women find helpful in their education that then also resulted in a resolution of pain. There's excellent studies looking at back pain and the psychological element there, where up to 70% of patients with chronic back pain after treatment of any organic cause is then treated psychologically. There is no such studies for pelvic pain, and this paper was basically trying to replicate a curriculum from the back pain studies, and so that people can take this forward. Next slide, please. So their aim was to see what worked. They had 36 women, so it's a small study, but they interviewed all these women and they did extensive surveys, so quite time intrusive for these things. Next study, please. So in general, most of the patients, especially nowadays, just correlate that their pain, there's something in my tissues, something that's causing this pain that then is giving a signal. Well, as we all know, pain is more multifactorial than that, and is really linked to many different things, from the patient's mood to the patient's knowledge, patient's health beliefs, the situation, and then we can go deeper. We know where it comes from, endometriosis. We're understanding more about the nerve element, where previously people have spoken about distances to nerves from inflammation and causing the pain. We know about nerve sensitization, and we know about chronic pain in the brain. So it's a lot more, and part of pain education is explaining to the patients this complexity and the interactions that all these different elements can take. Next. So specifically, which again, I'm not going to, the aim is not to teach people how to do this, but this is more of a psychologist's job to do. It's more to appreciate. And in our consultations, what words or statements we can use to start that journey with the patients where we're being more positive. So patients really appreciated when metaphors or analogies were used in explaining their pain, made these abstract, very ununderstandable things more memorable. So using things like using the pain as an alarm for when something is damaged, and explaining to the patients that if someone has had an alarm go off for a long time, the alarm can become hypersensitive to even when there is no damage. So explaining neuroplasticity and central sensitization in simple ways that they can understand. Using personal stories and examples, maybe not so much us, but encouraging patients to go to groups and to seek other patients would be how they would get that, having that group interaction, feeling that they're not alone, explaining to the patients that this is very common. I find whenever we're doing the pelvic pain team and patients ask about waiting lists, and I say the entire clinic is people like you, they're shocked thinking a whole clinic every week is filled with people in that same situation where they feel alienated at home or at work with their condition. Those were the core messages, and then telling them, giving them hope in that these things can change, and by understanding the pain, things can get better. This is not replacing surgery. This is mainly for patients after surgery. Next slide. So we are first fighting the invalidation they've experienced in their life. We're improving. If the patient first feels heard and understands their condition, they're way more engaged with their treatment. We're explaining things early will give us a good success, using the tips I spoke to before, and that combination works the best. And we're using our our psychologists, if we have them, or asking patients to. There are different ways that people can get access to psychological input. And there has been one study published that is referenced in this paper showing that pelvic physiotherapy, if combined with pain education, improves. Next slide. So to the take-home messages, the most important part of any paper is they've split it into 4 different themes. So a sensitized nervous system leads to an overactive pain. So explaining this to a patient simply, validating the patient's pain, despite that they've had their endometriosis excised, was seen as very important and very useful in success for these patients. Dissociating pain from damage and injury was very important in these patients' healing journey. And then also explaining how the patient's feelings and thoughts on the pain can alter the perception of the pain. And then finally, and most importantly, telling them that this can get better. It's just a very long journey and there is risk of relapse, but that does not mean that it's not worth the effort. There were many, many different quotes from patients in this paper, but the one that stood out to me the most is the one I've copied here on the left. So she said, understanding that the pain is a protective mechanism, so switching it to a positive thing, it is the response of the body being hurt or damaged, but persistent pain can be a sign of overprotection and may not always mean that the body is an actual threat. So I think that was a very nice explanation of acute pain changing into chronic pain. Next slide. So again, I put that as a reminder, combine it with physiotherapy. And this is a book that is mainly developed for back pain, but it really goes through a simplified approach on dealing with chronic pain in general, assuming a patient has been treated or there's been no organic cause found. So if you work in a practice where you don't have access to psychologist or psychotherapist or anyone or online platforms, then earmarking certain books. So this is a book I personally read before I recommended to the patients, and I found it very useful and very clear. Could be another way to improve your patients post-operatively if they're persisting to have chronic pain. Thank you very much. Was that 5 minutes as promised?
Thank you. Thank you.
So can I just ask you, was this an opinion paper or did they actually do a study?
So this was a study of patients who have improved with this method, looking at there were so many different methods from therapy to group to self-help. And then they saw what elements of this education did they find was helpful.
Okay.
Because
and what was the outcome of the study? I don't know if I've missed it, but
so the outcome was basically that if you tackle these 4 themes of how the pain comes, that chronic pain is not a dangerous thing, that there is a way out, then the patients are more likely to be successful. But the main objective of this paper, there is no actual pelvic pain education curriculum. There is for back pain, and that has a lot of evidence behind it. But this is an inspiration to for us to take that to the next level. So they developed the curriculum, and then they want it to be taken to the next step.
Okay. Fine.
You want to add anything else, Mikey, on the subject?
A lot, but I think we're going to run out of time.
I think we can do like a whole 6 hours lecture about this.
Yes. So are we moving to who is presenting next? Is it the invited speaker?
We have a featured article next.
Featured article.
Yeah. So thank you for Hannah Bank to come and present here at the LEJEndo. I'm really looking forward to hear your presentation. So Hannah Bank is a senior statistician that works for National Statistics in London. And here with us, there is also Isabel Ward, that is a principal statistician that works for National Statistics, again, London, and I think in Bristol as well. Unfortunately, like I mentioned at the beginning, she lost her voice recently, so she's going to be with us, but the paper is going to be presented by Hannah. So the floor is yours, Hannah.
Thank you. Can you see my screen, my slides?
Yes.
Yes, great. Thank you. Yeah, thank you very much for inviting us to speak today. Yeah, my name's Hannah Bank from the Office for National Statistics. So me and Isabel, we recently worked on a study that looked at the characteristics of women who were diagnosed with endometriosis in an NHS hospital in England between 2011 and 2021. I'm just going to give an overview of this work. So first of all, why did we do this study? What's the background? So using data to understand women's health is a key government priority at the moment. And if you look at the Women's Health Strategy for England, it's outlined that there are existing evidence gaps and more research is needed in this area. And at ONS, we have access to the individual level census data. So our aim was to utilise this population level census data and be able to link it to individual level hospital admissions as well, to then examine the characteristics of women who are diagnosed with endometriosis. And there's a blog online, there's a QR code that you can scan that then gives a bit more context and background as well to the work. So the data sources in this study, we use the ONS's public health data asset, which we've used for other ONS work as well, and it links the 2011 census to NHS hospital records and also death registrations. There's a paper as well, another QR code that you can have a look at, which goes into the linkage in a lot more detail as well. But for this particular study, we then linked the 2011 census to death registrations and then the NHS hospital episode statistics admitted patient care data. So we linked by NHS number via the 2011 to 13 NHS patient registers. So our study was a retrospective cohort study of people who were enumerated in the 2011 census, self-reported as female in the census, were living in England, and also they needed to link to the patient registers to be able to obtain an NHS number. And so our study period was looking from Census Day 2011 to the end of 2021. We looked at two separate outcomes in this analysis. So if you've looked at the preprint online, then the ordering is a bit different. Just from some feedback, we've restructured it slightly. So our main analysis is the outcome for the main analysis is at least one primary diagnosis of endometriosis using the ICD-10 codes N800 to N809 in the hospital admissions data. So both outcomes were done as a binary flag. And then we also excluded anyone that had any evidence of a pre-study diagnosis. So we have HEADS data back to 2009. And we also excluded anyone who had only a secondary diagnosis, but not a primary diagnosis during our study period. And that was because we were trying to estimate incidence of diagnosis, and so we wanted to be able to assume that any diagnosis during the study period was the woman's first diagnosis. So in our main analysis, we had about 120,000 women with a primary diagnosis, and then a control group of around 24.3 million women. And then in our secondary analysis, we looked at any mention of a diagnosis of endometriosis, whether primary or secondary, in the HEADS data. And that was trying to estimate the underlying rate of diagnosis. So in this secondary analysis, we had 262,000 women with a diagnosis, and then again a control group of around 24.3 million women. And then we had a range of demographic exposures that were all as recorded in the 2011 census. So looking at age group, ethnicity, we looked at socioeconomic variables, health variables, and also some geographical variables as well, to look at differences across different characteristics. So our statistical analysis that we performed, so we looked at descriptive statistics, such as method of admission and age at diagnosis. We looked at age standardized rates per 100,000 people. And then we looked at logistic regression to estimate odds ratios of diagnosis, where we first adjusted for age, and then also secondly for age and health. We didn't use the health variables from the census here, such as general health and disability status, because we wanted to ensure that we weren't including any symptoms of endometriosis there in how women were reporting their health. So instead, we used a proxy for health by looking at the number of pre-study diagnoses, pre-study hospital admissions, which did not mention any diagnosis of endometriosis. And then for sensitivity analysis, we also looked at a 2-year follow-up instead of a 10-year follow-up, just to check the robustness of our findings. So first, looking at some descriptives. So here we have a count of first endometriosis diagnoses by month, going back to census data 2011. So the dark blue line shows the main analysis primary diagnoses only, which you can see are generally consistent over time, but then we see those 2 sharp drops from the 2 COVID lockdowns. And then the teal line is where we also include any secondary diagnoses as well as primary. We do see a slight increase in trend, which seems to be driven by those secondary diagnoses, possibly due to an increase of admissions for other conditions as well. Looking at age at first endometriosis diagnosis, so this is for women aged 15 to 85 years old. Again, the main analysis is the dark blue line, where we see quite a symmetric bell curve covering the reproductive age of women, with a mean age at first diagnosis of 35 years. And then when we include those secondary diagnoses in the teal line, we see it skewing slightly older, with a mean age of around 40 years of age. So moving on to some odds ratios for the main results, where we look at primary diagnoses. So here we are looking at the detailed ethnic groups. We had the white British group as our reference category, and you can see all the other ethnic groups had a significantly lower odds of diagnosis compared to the white British group, except Gypsy or Irish traveller, which has quite a wide confidence interval. And we see the groups with the lowest odds of diagnosis were the Chinese group, the Black African group, and also the Arab group. And just to note, these models are all adjusted for age and health. Looking at some other characteristics, so first of all, looking at main language, where main language being English was the reference category, we found a significantly lower odds of diagnosis for women who did not have English as their main language. When we look at index of multiple deprivation, we had decile 10 is women who are living in the least deprived areas in England. And then decile 1 is the most deprived areas of England. And we found that the women living in both the most and least deprived areas had the lowest odds of diagnosis, and we saw a bit of an arc curve there, which was then we found it consistent as well below with highest level of qualification, where it was the women with the lowest levels of qualification or no qualifications, and the women with the highest levels of qualification that we were found to have the lowest odds of diagnosis. That was also the same for when we looked at national statistics socioeconomic status. And then looking at disability, where women who reported not being limited in their day-to-day activities as the reference category, we found significantly higher odds of diagnosis for women who reported being limited a little and also limited a lot. Moving on to the secondary results. So this is the primary and secondary diagnoses included. And the pattern is generally similar to the main analysis. 2 points that of note are the mixed white and Black Caribbean group and the Black Caribbean group. Their odds actually became, we found no significant difference compared to the white British group here, whereas before for the main analysis, these groups were found to have significantly lower odds of diagnosis. Otherwise, results are generally similar. Looking at main language, that's again similar to the main analysis. Looking at deprivation level, Before we had the most deprived group, decile 1, having, we didn't find a significant difference to decile 10, the least deprived, whereas when we look at secondary diagnoses as well, we did find evidence of a significant difference for all groups 1 to 9. And then also for disability, we found that women who reported being limited a lot, their odds increased, they were higher compared to the main analysis. So just to mention some limitations and considerations. So we know we're undercounting here. We're only looking at women who were in census 2011 and could be linked to the NHS patient registers. And we're only using the NHS hospital admissions data here. So we know that some women will be receiving treatment from primary care, but maybe don't have a hospital diagnosis, or some women would be under private healthcare, and they wouldn't be captured in our study here as having a diagnosis. And then also just to note that the differences that we're seeing could reflect differences in likelihood of having endometriosis, but also the likelihood of actually receiving a diagnosis in an NHS hospital, thinking about groups having maybe more barriers to getting a diagnosis. We know that there are other factors not accounted for here, such as access to services, family history of endometriosis, etc. And then finally, just to note about logistic regression, where we aren't accounting for differing time at risk, and also some women were recorded as having multiple diagnoses, but we created a binary flag, so it's just has a diagnosis or not in our study. So for our key findings, so we estimated the underlying rate of endometriosis diagnosis in an NHS hospital to be approximately 2% of reproductive age women, with an average age of first diagnosis of 35 years. For ethnic group, we found that the likelihood of diagnosis was highest in the white and mixed groups, and then lowest in the Chinese, Arab, and Black African groups. Women living in the most and least deprived areas were least likely to have a diagnosis. So as I mentioned, this could reflect barriers to seeking treatment, or potentially longer waiting times in the most deprived areas. And then in the least deprived areas, perhaps there are women getting diagnosed in private healthcare. And then for health, we found that women reporting to be in bad health or disabled were more likely to have a diagnosis compared to those in very good health or not disabled. So just quickly to also mention a follow-up that we've done, and we recently published in February, where we've also looked at the impact of having a diagnosis of endometriosis on women's labour market participation and progression, where we've linked this data to HMRC employee data. So I don't have time to go into detail, but so here we had a group of 55,000 women with a primary diagnosis between 2016 and 2022 and age 25 to 54. And we used some fixed effects regression modelling to look at the effect of having a diagnosis of endometriosis on monthly pay and the probability of being in employment. So we adjusted for age, calendar time and births, and then deflated all pay to 2023 prices for comparison. And so in this chart, we're looking at the effect on pay for all women from month 0, which is the month of diagnosis, the first part, looking 5 years post-diagnosis. And you can see we found significant decreases in pay, and 4 to 5 years after diagnosis, pay decreased on average by £130 a month. And then looking at women who are actually in paid employment, we again found a significant decrease to £56 lower per month on average 4 to 5 years after diagnosis, comparing to the 2 years pre-diagnosis. And then finally, looking at the effective probability of being in paid employment, again, found a significant decrease, which reached 2.7% lower likelihood of being in paid employment after diagnosis. So looking at the impact of this work, so very recently National World, they wrote an open letter to UK health ministers calling for improvements in treatment, and they cited our work in this area. And we've had some broad media coverage on both of the studies that I've talked about today. And then our next steps for this work. So we're currently drafting an academic paper for the labour market work we briefly went through, which we hope to make available within the next month. And I mentioned a limitation of our work is that, you know, we're only looking at hospital data. We don't have access to the primary care data, but we have an ongoing collaboration with the University of Leicester, where they have access to the primary care data, and we're looking at the time between symptom presentation in primary care and then diagnosis in hospital data. And then finally, for the labour market work, we're planning to replicate our work linking to benefits and self-employment data as well. That's all. So there's links here. I can put any in the chat as well if you like. Happy to take any questions.
Thank you so much, Anna. Fantastic presentation and impressive paper, really. We have a few questions from the audience. I'm going to start from Jess Prisho. Hi, Jess. So she's congratulating for the data, very interesting. And she just would like to clarify, was it a diagnostic was a laparoscopic diagnosis of endometriosis, or was the diagnosis done through also ultrasound, MRI?
So in this study, we looked at the diagnosis codes of the N80 codes. We haven't looked at the procedures, which is something we think would be really good to look at as well. But yeah, that's not included in this work here.
Hi, Hannah, just a quick one from me. So the ICD-10 80.0 is the code for adenomyosis, is that right? And 80.9 is the endometriosis code. So you're looking for both, is that correct?
I don't remember the exact descriptions, but it was the 80.0, like all of the 80 codes, but I don't remember the exact wording of them.
So that would be, from my perspective, I think that would be really interesting to see how was the diagnosis made. Was it based on surgical findings, or was it based on images, etc.? So that would be really interesting.
Mm-hmm. Yeah. Okay. That would be definitely very interesting. I know Isabel's spoken to other clinicians as well, so it'd be really good to actually look at the procedures of how the diagnoses were made. So I think that could be an extension of the work.
Yep.
We have also a question from Kartika Lestari. She was wondering if you notice or if you in your study, if there's any difference in prevalence of endometriosis between urban and non-urban areas.
Off the top of my head, I don't think there was a strong difference. Yeah, I'm struggling to remember off the top of my head, but I think there was possibly a slight significant difference that we found, but I'll have to check. But yeah, it'll be in the paper we did publish. Yeah.
That's only everything we needed to know. So this is a perfect excuse for everyone to go and read the paper in details. And does anyone else wants to ask any other question for Hannah? Mikey?
Oh, has a hand up.
Yeah. So thank you so much for the lovely presentation. I don't know if I've missed this during your presentation, but I noticed that the conclusion you mentioned that the incidence or the diagnosis of endometriosis was 2%. And obviously there's a lot of literature that quotes 10%. Is there any reason for this difference?
Yes, yeah. Yeah, so I think there's like two main points. I think the first is that we're not capturing all women in our study in England. you know, as I mentioned, we could only capture women in the census who also linked to be able to get an NHS number for them. But I think the second larger point is the limitation of only using the hospital admissions in an NHS hospital. So there are going to be women who don't have a hospital diagnosis. There will be women who are receiving treatment in primary care, or potentially undiagnosed as well, or misdiagnosed. So yeah, that's, I think, probably the biggest limitation of the study, is that it's restricted to the hospital diagnoses. So we really hope at some point we could get access to primary care data as well, and include more women that are showing or perhaps suspected endometriosis.
Pablo?
Thank you so much. That was an absolutely amazing presentation. I just have a question. I don't know if it's already been covered. Apologies if it has. But in terms of the ethnicity of the patients and the odds ratio of being getting a diagnosis of endometriosis, was there any correlation between the ethnicity of patients and English as an additional language? And you look at that, so if the race was and language had an impact.
Yeah, that was something that we thought about. So in the results that I presented, we've adjusted for age and health status. But in the paper, for ethnicity, we've also included some model results for where we adjust for country of birth and main language as well, to look at whether the differences were down to the access to services, you know, barriers, for instance, yeah, as you say, language barriers, for instance. But we still found significant differences between the ethnic groups, so it didn't change the findings there.
Great, thank you.
Thank you so much, Anna. So really, thank you for presenting this fantastic paper. I think we can move on with the last two short papers. You're more than welcome to stay with us and give us your input if you want to any of the next papers. Before moving on with the, I think it's you, Pablo, presenting next. And Jess Brishaw made a really nice comment for the paper presented by Oscar. And yeah, it's a good point actually for seeing the difference between improvement of your skills between laparoscopy and robotic. It would be nice to have medical students as cohort which have pretty same level of skills between the two modality. What do you think, Oscar?
Yeah, I like the sound of it. I'm sure all the doctors fighting to get on robotic technology won't be very happy at the idea of the students coming through. But I think that's where the main cohort would have to come from. Them or the early, like either the foundation year trainees that come to our gynae, or even just like ST1s across the country with, I don't know, working with the BSG or something. It'd be a really interesting way to look at it.
Right, Pavle. So this is your master, Pavle.
Yes, so I have the unfortunate role of following such a great presentation with my master's thesis. So this was performed in October of last year at the Canterbury Christ Church University in Kent. And the title of the paper was Urinary Tract Endometriosis Leading to Renal Impairment, Silent Kidney Loss. Can we prevent rather than treat? So in terms of the background of why this is important, we know that endometriosis can affect lots of parts of the body, but only 12% of that is outside of the genital tract. And endometriosis that affects the urinary tract system most commonly affects the bladder, but will also affect up to 23% of the time the ureters, and that can be both intrinsic and extrinsic disease. Given the prevalence of endometriosis, as April's mentioned before, our literature suggests 10%, and we can conservatively estimate that about 350,000 women globally may be suffering from this. And obviously, endometriosis on the ureter can cause complications, and the length and severity of endometriosis leading to obstruction determines the impacts that it has on kidney function. So acute hydronephrosis, seen sometimes with, for example, an obstructive renal calculus, doesn't have a long-term effect on the EGFR or kidney function and is limited and reversible. However, slowly progressing disease or anything that causes chronic hydronephrosis, even if the obstruction is resolved, can lead to basically thinning of the parenchyma, fibrosis and cortical atrophy, so a silent loss of the kidney and its associated complications. So the aim of the study was basically to see whether or not we can see any ubiquitous features in these patients who have presented in the literature, to see if we can screen for it and hopefully catch the disease before it causes these complications. So on the next slide, we move to the methodology. So this was a literature review looking for all case reports, series, cohort studies, cohort trials from the conception of the databases listed there up until December 2024. And the inclusion criteria are basically any women with a histologically confirmed diagnosis of endometriosis who underwent surgery for management of deep infiltrating endometriosis affecting the ureters, leading to either renal function decline, loss of kidney, or a combination of the two. And exclusion criteria were obviously any women who had pre-existing renal conditions and women who didn't undergo surgery for their management of endometriosis. And the primary and secondary outcomes of the assessment of the study were looking at patient demographics, so age, parity, previous surgery, clinical symptoms and investigations, radiological findings and intraoperative findings, and if stated, surgical treatments, outcomes, complications were noted and analysed. So the initial literature search showed a total of 84 articles, not much, and deduplication tools were applied to the databases, removing 47, so bring us down to only 37 articles in existence, and 27 of these were excluded for the reasons listed in the Prisma diagram that we have there. So giving us, on the next slide, we can see there's a grand total of 10 studies that were deemed suitable, so a really small number, only 36 patients that we can see. The studies were undertaken in 8 countries, all in single centres, and all the papers identified were either case reports or case series with one retrospective cohort study. Unfortunately, there were no randomised or non-randomised control trials identified. And given the paucity of data available for this study and no true available control group, we decided to compare all available data from the case reports and case series, which we'll call the CS group, to data in the solitary retrospective cohort study, which was undertaken in Barcelona. And the non-renal loss patients in that are sort of the de facto control group for paper. In terms of the results, within our analysis, on the next slide, we can see, oh, sorry, I think we're fine. Apologies, the little red bars have moved, and I think there's 1 or 2 missing that should have been sent across, but apologies. But we can see that patients were of a similar age, but there was no information on ethnicity in any of the studies provided, and no recordings of BMIs aside from the RCS group, the Barcelona study. The majority of patients in both groups were nulliparous, and in the CS group, so the cohort studies group, the case series group, 75% suffered with primary infertility, which was significantly higher than in the non-renal loss patients within the RCS group, our de facto control group. Our findings of chronic pelvic pain were higher than in the Barcelona study, and we think this may be due to over-reporting in the case series patients. And that's because the Barcelona group required patients to score 7 or higher in their numerical rating score to be classified as having chronic pain, and only 1 study in the other group used a similar quantitative measure. So in future studies, basically, we need to see a quantitative reporting system that's ubiquitous amongst all papers to correctly identify if this is a risk factor. Higher rates of dysmenorrhea were seen in both groups, which seemed promising. However, in the RCS, the Barcelona group, this was not statistically significant when compared to our non-renal loss patients. And as a result, we aren't able to recommend that this is a potential finding for a predictive factor for renal loss. Over a third of patients had dyspareunia and dyschezia in the CS group, and that unfortunately goes against the Barcelona study where no patients recorded these findings, and our results were similar in nature to the non-renal loss patients within that group. Another interesting finding is that for almost all of our patients with renal loss, there were no urinary symptoms in either of the groups. And of the three studies that did do urinary function testing, all of those came back as normal. On the next slide, we talk about other signs and symptoms that these patients might have, and similar numbers in both groups had undergone previous obstetric or gynecological surgery. Within the CS group, 40% had previous adnexal surgery. Unfortunately, though, the Barcelona group did not break down any differences in the type of surgery. They merely stated previous endometriosis or non-endometriosis surgery, and there was no way of differentiating if patients had had one or the other or both from the information provided in the study. Our study hypothesizes that previous surgery, particularly adnexal surgery, as we can see, or pelvic wall surgery may be a predisposing factor, potentially from scarring, for ureteric endometriosis and subsequent renal loss. The exact mechanism we're not really certain, and obviously we need further investigation with a larger pool of patients. Pelvic examinations at time of initial assessment for patients showed perceived normal anatomy in only 28%, and the majority had a variety of descriptive findings, but almost ubiquitously had a painful enlargement or palpable nodule in the posterior aspect of the vagina. Unfortunately, in terms of the quality of the reporting, even the Barcelona study didn't say whether or not these patients had pelvic examinations. The point that we found, which was quite interesting, is that within the case series group, few patients had a new diagnosis of hypertension at an early age, which we ultimately later in the study assumed this was as a result of atrophic kidney loss causing secondary hypertension, as we know that unilateral hydronephrosis has been shown in case studies and in animal studies to cause hypertension. In terms of imaging modalities used, on the next slide, we can see that the CES studies either had a transabdominal, transvaginal ultrasound, MRI, or CT, depending on center practices, whilst in the Barcelona group, they were initially assessed using ultrasound. However, if they fully weren't able to stratify endometriosis, that an MRI was performed. This meant that pooled radiological findings for both imaging modalities, or all of the imaging modalities we used in the analysis, and we're not able to quantify findings just for ultrasound or MRI because of the pooling of the data. Bias of reporting may have also resulted in certain findings being omitted or included to add weight to each individual case report. And aside from the Barcelona study, there's no documentation for why an imaging modality was chosen as first-line preference in each unit. In terms of the actual findings within the imaging modality for the pooled, we can see that there were lower rates of adnexal endometriosis and intestinal nodules of endometriosis found in our analysis than the Barcelona one. However, there were higher rates of non-intestinal nodules seen in both groups. Okay. In the figure on the right shows that nearly 62% of case series patients had kidney loss affecting their left side, with a mean function of only 7% of that kidney on renal scintigraphy. And it looks more like it was a chronic picture than an acute one. Once again, unfortunately, the Barcelona study did not indicate individual kidney function, so we weren't able to compare that. Moving on, in terms of bowel surgery, within the CS group, nearly half of them underwent predominantly sigmoid resection with anastomosis, and this was slightly lower than in the RCS group, but they're not able to give us a further breakdown of the subtype of the surgery that was performed. Over 60% of CS patients had a ipsilateral nephrectomy or nephrouretectomy, whereas in the Barcelona group, this was only seen in 33%. In terms of duration of follow-up, when documented within the CS group, this varied from 6 months to 48 months, and the majority of patients were asymptomatic following surgery. Mentioning again, 2 patients underwent secondary nephrectomy due to worsening hydronephrosis, and interestingly, one of these patients within that group developed hypertension following non-removal of the atrophic kidney, and their hypertension resolved on a secondary procedure where a nephrectomy was performed. A separate patient within that group, who also didn't undergo nephrectomy at the time, developed hypertension, medically managed, but we can see that hypertension can be caused by this condition. So, in summary, what this study showed is that there's an extremely limited pool of information available regarding urinary tract system endometriosis, its subsequent renal complications in the literature. Despite this, our findings are that women with infertility, previous abdominal surgery, the absence of urinary symptoms, evidence of deep infiltrating endometriosis, palpable on examination, or non-intestinal nodules on imaging, as well as early onset hypertension, could be things that we need to look out for in order to prevent this disease. There's understandably a lot of limitations with my work. There's a really low strength of studies due to the rarity of the condition and no true control group, meaning we weren't able to perform any meaningful or higher statistical analysis. And there was a significant lack of consistency for reporting within the studies which hindered this work. What we discussed at the end of this study was basically creating a proposed standardization of a reporting framework and international database similar to what the BSGE does, in order to get more comprehensive and robust studies to confirm the findings that we have and advance our knowledge in the area.
Thank you, Pavle. Well done for this master. It's a beautiful paper. Honestly, you need to be proud of it.
Oh, that's very kind, Ben.
Can I ask you something, Pavle? Because with Mike Adamczyk, I think like we had a few patients actually which had kidney loss that came to us already with severe endometriosis and impairment of their kidneys. Did you find anything in the literature to advise for asymptomatic patients with non-severe endometriosis, posterior compartment disease, bilateral endometriomas, these kind of patients, how often they recommend, for example, to do a follow-up ultrasound of their kidneys? 1 year, 2 years, 5 years?
So the problem with the information available on the databases is that because of the rarity of the condition or perceived rarity of it, they are basically case reports where they say that this was a finding that was seen, surgery was performed, and then a simple follow-up of whether or not they had anything. And most people would say they were asymptomatic. We don't screen for blood pressure in these patients routinely, so we don't know if they had pre-existing hypertension that was resolved or not. And there's no data available apart from the Barcelona study as a retrospective cohort in terms of if we should be regularly screening them. So no, unfortunately, there isn't.
I'm gonna pass the ball to Mikey then. In your experience, in your practice, do you do ultrasounds often?
So we do. I think it's important to notice that I'm not aware of any consensus when it comes to scanning kidneys specifically for patients with posterior lateral disease, the ones that we really worried about, ureteric obstruction. I'm probably more on the cautious side, and I would prefer to have a scan probably on the first EF every 6 months, and then repeat a scan on yearly intervals. That is my practice. But there's, again, no consensus of how often you should scan those patients, whether they should have an MRI, whether they should have an ultrasound of the kidneys. Economically, ideally, everyone, I think, would be the best for patients to actually have an MRI to see what's happening to the urinary tract. But understandably, that's not feasible for various reasons, mostly financial, in the NHS. And therefore, the next best thing is really to look for hydronephrosis of the kidney to see if there's an obstructive cause that is causing it. And that's quite a good test that is not expensive, and it can be fairly easily done.
Yeah.
So
You made very good points, and I think and it's good. It's easy for the patient as well. Doesn't have to wait long in the hospital. The GP himself or herself can request it and do it, and let us know if there's any problem. And I don't know if you remember. I think we had a similar chat in one of our LEJEndo. It was also Alan Constantine. Do you remember?
Oh yes, Alan. Yes.
Yeah,
He
I
was
think
saying similar thing, wasn't he?
I think if I do it yearly as well, I mean, I'm like you, I prefer to be safe rather than sorry, and I request them yearly. And if at some point we discharge them from our care, I advise the GP to carry on with this practice.
Yeah, 100%. And that's another sort of argument, I guess, that, should those patients be discharged back to primary care with a diagnosis of severe endometriosis, right? Should we
Yeah.
should we be all following them up lifelong?
Yeah.
The answer is that we probably don't have enough clinics, enough specialists to do that. But that I guess is a question for a different debate. But that's something to think about it, right?
Yeah, absolutely. And Jess made some good points. Would surveillance scans in the patients in this study have protected them from having kidney loss? So, did you manage to extract any of this information, Pavle?
Sorry, my connection went for a second. Could you say that again?
So, just pretty sure, first of all, she's complimenting for your paper. It's very good. And she's asking, would surveillance scans in the patients in the studies that you listed protected any of these kidneys? And is it possible to extract from your studies if potentially the kidney would have been saved? I think it's difficult. Probably
I think it's really. I think you're right. I think it's really difficult. And for example, the Barcelona study, which had non-renal loss patients and renal loss patients, these were all people who. So every patient that came into the Barcelona center would have an ultrasound, would be screened, and these were people who had an incidental loss that was seen, and they'd all been referred with chronic pelvic pain, and by the time they arrived, the kidney had already been lost. So there was nothing that they could do. They don't mention anything in terms of follow-up as to whether or not, after the surgery, if they would have any scanning either.
And we can take the last question from Kartika Lestari. It's a difficult question how to answer. If after dialysis the ureter is compressed, is released, but ureter still looks narrowed, what should we do? Ureteric resection implantation, pop stents, and follow it up. I think it's difficult, isn't it, Mikey? Because we wouldn't do these things by ourselves if we think that is kidney loss of kidney function and there is a hydroureter. We would have a urologist there with us to also guide us and advise us.
Yeah, I mean, I think it's important to remember that reimplantation is we do it quite often, but it has its own morbidities and its own risks. I think personally, if you've excised, and we've done it a lot, if you've excised compression, the assaulting factor on the ureter, and there's no intrinsic disease, and you've freed that ureter completely, then it might look slightly stenotic, probably stents, for a few weeks. And you can do a urogram to see what the ureter looks like after the stent removal.
Absolutely, yeah. Well, thank you everyone for joining us, and we're going to see you in a month's time. Thank you for all the team of LEJEndo. We've done such a good job finding all these papers. Thank you for Hannah. Thank you for Isabel for presenting this fantastic paper. And we'll see you shortly.